Or I'm like, no, I need you to get that. You need that.
All right. So, hey guys, I'm Sean Casey, one of the secondary residents at Sarasota Memorial. Not sure if I've met any of you guys before. During my last rotation, I did EMS with you guys last month. So I appreciate you guys having me. Thanks for letting me present today. So, a little background on me. I'm from Florida, from West Palm Beach originally. Went to FAU as my undergrad. Went to medical school at LECOM down the street here in Lakewood Ranch. And now I'm here stuck with Dr. Frank. So I'm going to talk about TXA and trauma patients today. So TXA is also called tranexamic acid. It's used in trauma patients supposedly to help decrease the blood requirements when transfusing patients, also to possibly help decrease the bleeding and all-cause mortality. So today I have 3 cases here that I'm going to discuss. 2 of them are going to be more of an in-hospital study that has done a study throughout the world, multiple different countries, thousands of people were involved. And then I have a pre-hospital study regarding TXA that will kind of hopefully convince you guys that TXA would be a benefit in the field to give to our trauma patients, either blunt or penetrating trauma. To start here, I have a sample case. So this one here is briefly based off of a real case that I had last year when I was on the trauma service at SMH. So this guy, he was brought in by EMS rather quickly. He was called because of blunt trauma. He's a tree trimmer, mid-30s or so. The story was that he was up in the tree with his gear, cutting a pretty large limb down. It's probably about 500 pounds. And it kind of got caught and pinned him. Pinned him against the trunk of the tree for 30 seconds or so. And you can imagine that weight and pressure hitting his stomach. The amount of pain he might have been in, what kind of trauma he was in. EMS arrived and he was anxious, he felt lightheaded, and he had like a painful distended abdomen at that time. Obvious injury to the abdomen as well. Next slide. So again, these are sample vitals to just give you a kind of idea of what he was kind of in. So obviously hypotensive, 90/55, tachycardic, he's afebrile, oxygenating well, he was a little bit tachypnic, distended abdomen. So our first thought with like injury like that, crush, blood trauma, we're thinking like a hemorrhage possibly because of his distended abdomen and his vitals. Possible interventions right now, I guess, would be like fluids, get his IVs going, rush him to the ER. They might just, I don't know if you guys have blood on certain trucks or not. No? Okay. Give him some large fluid doses to keep his blood pressure stable, rush him to the ER. All right, so a little background on TXA. It's an antifibrolytic, so what that does is it's breaking down fibrin. Fibrin is in the clots that kind of do cross-branching to form a clot to stabilize bleeding. This is a molecule that will kind of prevent that, because our typical clot burden, I guess, is that it stabilizes it. So we're going to impair our plasmin, which is another enzyme inside the blood, to prevent it from stabilizing that matrix and make clotting more beneficial for our patient, possibly in a severe bleeding type situation. Okay. So we have approved uses for TXA already, and then off-label uses, approved type uses, severe menstrual bleeding, hemophilia patients. Those are also some indications that are FDA approved. And surgeries like really bad orthopedic surgeries, big hip replacements, knee replacements, shoulders, other types of big surgeries. They've used TXA to help decrease the bleeding and decrease the blood transfusion requirements for those types of patients. Additionally, a benefit for TXA is that it can be given orally or through the IV, and it's equally efficacious. Here I have a brief diagram of different types of conditions that you guys can see it clearly from back there, but I highlighted the FDA-approved conditions that TXA is used for, so dental bleeding in hemophiliac patients, traumatic hyphema, so bleeding of the anterior chamber of the eye, and then when fibrolysis is contributed to bleeding, so you can use TXA in that. But other off-label conditions you see here, trauma, obviously, hemoptysis, GI bleeding are supposedly supposed to help when given TXA. So our first trial that I want to talk about here is a really large trial. It's called the CRASH-2 trial. So as I mentioned earlier, these large bleeding surgeries, the orthopedic surgeries, for example, they were using TXA, and they noticed that there was evidence that they required decreased blood requirements when given TXA during the surgery. And they kind of made a hypothesis that if you can inhibit the fibrinolysis, you can lead to increased hemostasis of these patients, so decreased bleeding, and have better outcomes for those patients. And they thought that maybe they could kind of branch this over to other types of settings within the medical areas, like trauma, for instance. So this trial, again, as mentioned, it was all around the world, throughout multiple countries, 274 hospitals, so it's quite large. A 5-year study, so May 2005 to 2010. Your eligible patients, you can see here, blood pressure has to be unstable, heart rate is tachycardic, so all the signs of hemorrhage with trauma. And then in order to get the TXA, or they wanted to study patients within a window of 8 hours of injury from a blunt or penetrating trauma. So they randomized their patients that they brought in from different trauma situations. One group is going to be a TXA group. They're going to give 1 gram of TXA over 10 minutes, and then once they get that and stabilize through the trauma team, they're going to get 1 gram of TXA over 8 hours. This was randomized, so every patient was given like a unique number. It was a blinded packet with either like a placebo, which would be normal saline, or TXA. The TXA was already pre-mixed in a normal saline bag, so you couldn't tell the difference between the two. And everybody that came in got one or the other, and instructions were packed inside that bag as well. So there wouldn't be a bias between the person giving it or the researcher. So here we have some outcomes. This is what the study was trying to decipher. So one of their main outcomes was if there's going to be increase or decrease in death for these trauma patients within 4 weeks of injury. Other outcomes they wanted to assess for: is TXA going to increase vascular occlusive events? When they say vascular occlusive events, they're talking about myocardial infarction, PEs, strokes, those types of occlusions. Is there going to need additional surgical interventions, such as, say, they do a laparotomy, which is opening the stomach, stopping a bleed? Is the TXA going to kind of prevent future bleeds or future complications? And then lastly, they wanted to see if there's going to be more transfusion of blood that's going to be needed. Is there going to be less, or is it going to be about the same from the placebo versus the TXA group? All right, so as you can see, there's a lot of patients that they did bring into the study. It looks like about 20,000 patients throughout the 40 countries. 10,000 were in the TXA group, 10,000 were in the placebo group. What they did find as significant for possibly pre-hospital cases as well is that all-cause mortality was significantly reduced with the TXA group. So that's saying that if you give TXA for these types of patients, the trauma, blunt or penetrating trauma, regardless of the necessary like injury, they do have a chance of decreasing their risk of death with given TXA and they're in a hemorrhage type state. The risk of bleeding was significantly reduced as well. As you can see, 282 TXA patients versus 355 placebo patients passed away from bleeding. So there's obviously a difference there. And then from vascular occlusions, it actually looks like there is less risk based on this. There's less MIs, there is about equal strokes, and then for pulmonary embolisms is about equal as well. This is 7 out of 10,000 people, so it's very low risk. You could say that this is also, there's not any risk with giving TXA to a regular hemorrhaging patient if you think that they're hemorrhaging. So as I mentioned, no significant difference between the groups. In total, for vascular occlusive events, 168 total, very low when you think about it out of the 10,000 people that did receive TXA. For blood product transfusion, slightly more blood transfusion requirements in the placebo group. This is not necessarily a significant number, but treatment-wise, you can see there's about 100 less people that did require a large amount of blood transfusion in the TXA group. Overall, a number of units per person is about equal, 6 for TXA group and 6 for the placebo group. So some other areas that they kind of wanted to analyze is like, is TXA beneficial at any time during an injury, or is it beneficial during like right when they get the injury, right when you arrive, or is it kind of like, oh yeah, I can give it to them kind of whenever. So time to injury seemed to be a very important factor. They called it the golden hour. So if you can get TXA within 1 hour of the onset of injury, onset of hemorrhage, then it seemed to have the most significant benefit for the all-cause mortality. Patients still did have a benefit between the 1 to 3 hour range for TXA from the time of injury. Greater than 3 hours, there didn't seem to be a benefit for TXA. And then let's see here. So overall for the study, there was 3,000 deaths from all-cause mortality, 1,000 deaths due to bleeding. Of those deaths, there's 489 in the TXA group, 574 in the placebo group. So this is a significant number here. All-cause mortality decreased when giving TXA in a hemorrhage patient from trauma. So this next trial here is kind of branched from the CRASH 2 trial, obviously CRASH 3 right after. This one is going to kind of focus on intracranial bleeding, intracranial injury. In the CRASH 2 trial, they did kind of categorize the injuries in the study, but specifically I wanted to focus on all-cause mortality in the previous one. CRASH 3, again, we're going to look at the head injuries, traumatic brain injuries. Also going to assess vascular occlusive events again, just because that's a very big concern when you're giving something that's supposedly supposed to increase your clotting ability to decrease bleeding. So the theory behind this is that tissue damage and edema occur when you have a traumatic brain injury. The TPA, which is tissue plasminogen factor, that's associated with worsened tissue damage and worsened edema in the brain, and obviously when you have swelling in the brain, that's going to lead to further poor outcomes, such as herniation. TXA counteracts TPA. That's one of its main factors and one of its uses as well. And then early TXA administration can theoretically reduce these risks of edema and swelling, decrease hemorrhage expansion, decrease those poor outcomes. So there was 2 previous studies. Obviously, I mentioned this earlier. CRASH 2 study was the main one. There was a second trial. It was a randomized trial showing that there's a reduction in hemorrhage growth and decreasing mortality with TXA administration. They, in the CRASH 2 study, when specifically focusing on brain injury, they also showed that there was decreased hemorrhagic growth, but they didn't have a statistically significant number that showed TXA was beneficial in brain death or brain injury. So they wanted to revisit here. And there was also not a very large patient study here. The only 270 patients had that brain injury in the previous trial. So again, international multi-center study. 29 countries were involved this time, 13,000 participants. So TXA versus placebo. Similar dosing. They pretty much took the protocol from CRASH 2, translated into the CRASH 3 trial, 1 gram of TXA for a loading dose over 10 minutes, and then 1 gram of TXA over 8 hours with normal saline. And the placebo continued to be normal saline as well. Some inclusions here. So within 3 hours of injury and GCS of less than 12, they wanted at least mild to moderate brain injuries, also severe injuries, obviously, if it's less than 12, are grouped in there. If there's any type of bleeding on CT scans from the hospital on the initial presentation, they're included. There can't be any significant extracranial bleeding, so no traumatic hemorrhage of like a limb, intra-abdominal hemorrhage, something like that. Primary outcomes they want to look at is head injury death within 28 days, and then secondary outcomes, the early death, 24 hours, 48 hours, what those look like, all-cause mortality, and vascular occlusive events as well. They wanted to analyze. So overall, we had 6,359 patients that were put into the TXA group from the overall 13,000 people. Obviously, they had to account for other types of people, so they took out people that were like less than 18 years old, took out people that didn't necessarily fit the inclusion criteria. In the primary outcome, it looks like risk of death was 18.5% in the TXA group, 19.8% in the placebo group. The main finding here is that TXA was found to be the most beneficial in a mild to moderate head injury with bleeding findings on CT. And this here, time of administration didn't necessarily matter. What they did find here is that patients treated soon after injury have more of a severe injury, severe head injury, so you're more likely to see a person that's got a severe injury and treat them faster than necessarily like a mild or moderate injury. And they want to say that that is what accounted to the no difference in time of administration for the TXA. And then the secondary outcomes, again, no change in vascular occlusive events between TXA or placebo. So here is a graph to help kind of explain the mild to moderate benefits and then the severe head injury with TXA. So on the left here, you have our mild to moderate GCS score. The vertical numbers here is relative risk. So the lower on that scale is the more likely that you'll benefit from TXA administration in a mild to moderate GCS score. And then here on the horizontal line at the bottom is the time to onset or time to treatment. As you can see, less than 60 minutes, or that golden hour, is the most beneficial time, as we mentioned in the previous study of the CRASH 2. So if we can get that TXA given to the patient within 60 minutes, they're most likely to benefit. The longer you wait in this particular category, their benefit kind of decreases. And then on the right side, you have the severe GCS, and you can tell it doesn't matter when you get the administration, but there's no necessary benefit. There's kind of a stagnant line there. Yes.
What are the two different curves on the top and the bottom?
Those are the ranges
okay.
of relative risks. So there's quite a big range.
Like the error bars?
Yeah, so when I believe a relative risk, if it passes 1, then there's no benefit between placebo and TXA. So the higher side of the range on the left graph of mild to moderate GCS. At about 180 minutes, there's not necessarily a benefit for TXA. And then on the right here, we're right at about 1, and we're crossing each side of 1, so there's no real benefit from TXA in the severe GCS group. And then here, this is kind of a overall type graph to encompass everything here. That top dotted blue line here is our severe head injury patients. Again, a relative risk around 1, so that's less likely to benefit from TXA. TXA and placebo are about the same. Our bottom 2 lines here are mild to moderate, as I just discussed. The longer you wait, the less likely the patients benefit from TXA. Most benefit is seen within that first hour, or the golden hour. Okay, and then, so that was the CRASH 2 study. So now I want to bring in more of a pre-hospital type study that is more geared toward EMS and how EMS may be able to help with patients who are having hemorrhage and possibly giving TXA. So this one here is the efficacy and safety of TXA and pre-hospital traumatic hemorrhage shock. And this is a CalPAT study based in California. They referenced the CRASH 2 study that I mentioned earlier, and then there's another study called the MATTERS trial. That's the military application of TXA in trauma emergency resuscitation. So there's all military type study. And with those results for the MATTERS trial, it kind of gave them a starting point. One of the things with the MATTERS trial is it's military and there's much more traumatic injuries compared to a normal civilian type injury. So that their results are a little bit more less significant for TXA. When requiring blood transfusion, their transfusions are much higher. But in here, for this particular study, we wanted to check the civilian population with blunt and penetrating traumas. They wanted to evaluate patients greater than 18 years old. And then they randomized these patients to TXA to placebo groups. I believe they used the CRASH 2 study as their criteria for types of dosing. As I mentioned earlier, the 1 gram initially, and then if they get to the hospital and need another dose of TXA, it's the 1 gram over 8 hours. In this study, they attempted to do a study with 400 total patients for TXA. They studied 200 patients in the pre-hospital setting and 200 patients in the hospital setting as well. So the pre-hospital would be that initial dose of TXA, 1 gram, and then the hospital would be the additional 1 gram of TXA. And they, in this study, they only compared pre-hospital group to their control group, which is the normal saline group. All right, so here, this is our inclusion and exclusion criteria for this particular pre-hospital study. The inclusion criteria is pretty much it's kind of an obvious criteria. Blunt or penetrating trauma, if they're hypotensive, tachycardic. They called hypertension, or they wanted to study less than 90 for systolic blood pressure. Let's see here, and are they high risk for significant hemorrhage? And they kind of estimate the blood loss by using a heart rate, and if they were uncontrolled with pressure. Our intervention group here, I mentioned already, getting a TXA dose in the pre-hospital setting, and then second dose upon arrival to the hospital after being evaluated by the trauma center and meeting more inclusion criteria. Sorry. And then the control group, they actually kind of used a registry to compare patients that did not get TXA. It's more of a retrospective, so they look back in the past at previous patients to the ones that they're bringing in for TXA. So in this study here, we had TXA that was administered by our paramedics or an RN that was in a helicopter unit. They followed the crash 2 protocol, as I mentioned earlier, 1 gram of TXA and normal saline over 10 minutes. Second dose was given at the hospital if deemed by the trauma team or trauma physician. That was given over 8 hours. Primary outcomes for this study, they wanted to determine mortality at 24, 46, and 28 days. And then we wanted to see if there was less blood that was needed to be given, and then vascular occlusive events. Obviously, everybody's concerned about blood clots. They used 10 EMS agencies over California area, 4 trauma centers. The average transport time is 22 minutes for this particular study as well. So overall, they had 156 patients in the TXA pre-hospital group. They didn't get quite to 200, but 28 patients were excluded due to either death before arrival, they're deemed non-traumas, or they are less than 18 years old because trauma, they might not have identification, you have to kind of guess. And then overall TXA administration here, we have a median time of 34 minutes, but it did range from 24 minutes to 45 minutes. All of those are within that golden hour that I mentioned earlier. And then about just over half were penetrating traumas versus blunt traumas for this study. Here I'm just kind of comparing our different groups here. You can see the percentages of each group regarding TXA, and then the control group, which they used for comparison. Overall, TXA had a lower 24-hour, 48-hour, and 28-day mortality, although I think the 28-day mortality was not significantly, not statistically significant number, although you can see a trend in the direction of benefit. There is significantly less blood product needed for our TXA group. There was no significant thromboembolic events in this particular study as well for the TXA group here. I was trying to see if I had the number. So total blood products used for the control group was about 7, just under 7. And then we have about 4 units of blood for the TXA group when it's administered in the pre-hospital setting and within the golden hour. So I mentioned this already, so trend is in decreased mortality rates for TXA group. Not all the numbers were statistically significant, but there's an observed reduction in mortality, which is what we're going for when we're giving this medication. There was a statistically significant decrease in blood products given for the TXA group. When comparing the hospital group, which is the group that received a second dose of TXA over 8 hours, we had a little bit of more blood that was given compared to the pre-hospital group receiving TXA only in the pre-hospital setting. And they suggest that this may be due to increased trauma burden, so those patients may need a longer hospital stay, more injuries that need repair or addressing. So as you remember when I first started, that sample case based on a real case that I had in the trauma, on the trauma team. We found the patient, he came to the ER. Hypothetically, if we give him TXA in the pre-hospital setting, that should have helped him significantly. He would have received less blood. Our patient did receive massive transfusion protocol. And this would be the type of patient that you would give that second dose of TXA over 8 hours as well. He was taken to surgery because he had a positive fast exam with ultrasound. And then he was taken to laparotomy because he continued to have distension of his abdomen. It became firm. He became altered as well. And when he was taken to surgery for the laparotomy, they found that he had a hemorrhaging superior mesenteric artery in his abdomen. So they repaired that, and they took out his spleen as well because there was some hemorrhage from there. Again, this is a sample case, but theoretically this patient would benefit from the TXA administrations, decreasing his risk of death and decreasing a possible long hospital stay. This patient actually was discharged about 8 to 9 days after the initial encounter. So, is TXA worth it? In my opinion, based on these studies, I think it would be beneficial for our patients, especially in the pre-hospital setting, especially if we give it within the golden hour time frame, because as I showed earlier, there's a relative reduction in mortality when giving it within 60 minutes. Also, you can give it within 3 hours, theoretically, and have a reduction of risk of death as well, but preferably within the first hour. It decreases all-cause mortality. We have a significant reduction in risk of death for mild to moderate head injuries, and possibly a decrease in blood transfusion. I say possibly because one study shows that there is a decrease in blood transfusions. Another study shows that there is not necessarily a difference because they were about equal overall. Again, TXA is also, I think, worth it. The studies in the pre-hospital setting show that there's no difference in transport times. They kind of compared it that the time it takes to start an IV and hook them up to fluids is the same time that you guys would probably start an IV and hook them up to fluids for TXA. So they show that there's no difference in transport times. Another benefit for TXA, it can be stored at room temperature, so we can keep it on the EMS trucks and not really have to worry about keeping it cold, so it would like denature. And then also it's very inexpensive. In the California study, a gram of TXA was approximately $16 to $50, depending on the situation. Compare that to a unit of blood, which is about $350 each unit. So it would save cost on overall like hospital stay cost for the patient and for the hospital expense as well. So future goals, if you want to implement TXA with the county, for instance, or even the hospitals, you got to discuss with your EMS teams, trauma teams, emergency staff, kind of implement a protocol to determine who would be in inclusion for that. I think these studies don't necessarily mention pediatric patients, so I think I'd probably stay away from pediatric patients giving this right now because there's limited studies. But anyone over 18 wants penetrating trauma, if you're within that golden hour, I think that'd be appropriate. And then Dr. Frank told me that he's planning on implementing TXA in January for administration. He didn't tell me his protocol, but I would assume that it would be very closely related to the CRASH 2 study, as every study we pretty much see is that 1 gram within for over 10 minutes within 1 hour of trauma, and then a second dose of 1 gram over 8 hours. And then continue to study your patient population, adjust the protocol as needed. Here are my references that I used for this talk. Tintinelli's, that's our emergency medicine textbook that we use in residency to further give ourselves knowledge. And then our CRASH 2 study, CRASH 3 study, and the California study. Any questions that I can try to answer? Yeah.
How did they fall on 1 gram of TXA as the appropriate dose to just start giving patients?
That's a good question. I can't recall off the top of my head exactly, but I know that in previous studies with like the orthopedic doctors that were doing those surgeries and found a benefit with TXA, they were giving about 2 grams during that surgery. I know 1 gram over 10 minutes is much less, but perhaps we can do another study to see if it's a larger amount is more beneficial, but they seem to show a benefit with the 1 gram.
And there's some systems that are giving 2 grams up front and not having the infusion after over 8 hours. Just like any other drug, there's a planning phase, and when you study these drugs, it probably came from the military that's been using TXA for a long time. Any other questions? So yeah, we, like Dr. Casey said, we will be rolling this out with a protocol, revisions in the near future. Our protocol is going to be for severe injury, so major motor vehicle crash, penetrating trauma to the chest or belly, you have to suspect hemorrhagic shock first, right? So if you suspect hemorrhagic shock, then you move on, and in addition to your regular management of hemorrhagic shock patients, our protocol, and we'll go over this in training a lot in the future, but just FYI, our protocol is going to be any suspected hemorrhagic shock with a blood pressure less than 70 systolic, any suspected hemorrhagic shock with a blood pressure less than 80 and a heart rate over 120, so that would give you a shock index of 1.5. Like Dr. Casey said, we're not going to use it for small pediatric patients. In collaboration with the Pediatric Trauma Center, we've decided to go with kids only over 12 and over, and we'll give 1 gram. Okay, so we'll give 1 gram over 10 minutes, and then the hospital will continue the other gram over 8 hours. The idea is that we think, if you can get it on board earlier for these patients with hemorrhagic shock, the better. So, our transport times are excellent, but the faster we can get this on board, the better. And then we will also be implementing a blood program, a whole blood program, that Captain Satterley and I are working on. And I want to actually, again, point out that Captain Satterley was incredibly instrumental in starting this TXA program. So thank you for that. And hopefully this was informative and helpful. If there's any questions, just reach out to your captains or Captain Smith, and we'll give you questions answered about TXA. Thanks.
Thank you, guys.